we have a series where we talk about the neonatal kidney. And I'm very excited to introduce Professor David Askenazi from the University of Alabama. I think most of us will know his name and his team in pediatric nephrology, but also from the Neonatal Kidney Collaborative and part of all the Awaken studies, which really have heightened our understanding of the neonatal kidney, consensus diagnosis, and a way to work and study these kind of babies. And he's going to talk today about a scenario which we all have encountered, hopefully not too often, but is challenging. David, over to you.
Thank you. I just want to confirm a couple things. So we are going for about an hour, is that correct?
Yeah, we'll do 45 minutes and then 10 minutes, 15 minutes discussion and Q&A.
Perfect, perfect. So this talk is one of three or four that we're giving, and in some ways it's in a reverse order. So we do apologize about that, but I know that Kara Slagle spoke to you guys about dialysis. I'm going to talk to you guys about what to do so you don't need to do dialysis. So this is kind of the medical management piece. And then Dave Selesky is going to come next week and speak to you guys a little bit about why this is also important. And so, in some ways, it's a little bit in reverse order. Ideally, it would have been like, why is it important? And then, what do you do medically? And then, what do you do if that doesn't work? So it's a little bit of reverse order. But my job today is to tell you my approach and what's out there to guide us to think about what we could do clinically to help these babies when they're not peeing so well. So just a couple of potential conflicts of interest to let you know about. I do consult for a couple companies that are trying to improve the care of neonates. I am the chief scientific officer for a company that I founded on making urine collection devices, and I'm not going to be discussing those products. So, um, in the in the holiday of Passover, there's a story about these four sons: the wise one, the wicked son, the simple son, and the son that can't ask a question. And we talk about how we approach those different things. And so I'm going to tell you a little bit about what happens in my dinner table when my children ask me, how do the kidneys work? They don't really ask me that, but really, no matter how you think about it, whether you're an academician, whether you're a clinician, whether you're a resident, from my perspective, we sometimes confuse everything. But as nephrologists, we make things very complicated. I'm not going to try to do that here. I'm going to I'm going to try to explain it from the perspective of how you can approach this no matter what level of thinking or what level of your career you're in. And so when you ask the question, how do the kidneys work? I think it all starts with recognizing that the main job of the kidney is to maintain homeostasis. And when we talk about what it's supposed to do, it's supposed to keep the balance of fluids, electrolytes, calcium, phosphorus, PTH, fluid, and water. And when it doesn't work, then it's up to you as providers to do the job for the patient. It's more complicated in neonates because the kidneys sometimes at birth don't really maintain good fluid balance. And so from the very beginning, especially in the very premature neonates, they rely on us to maintain that homeostasis for them. And when the kidney stops to work, it makes it that much more difficult. And anytime you're talking about homeostasis of any disease process or any body part, you could think about it from this concept here that there's going to be a stimulus where something happens in the body, either there's too much or too little, and there's a detection of that change by a receptor. And the receptor sends information to the organ, the kidney in this case, which then provides information outward to the effector, and then the response to the effector goes back, and it's a feedback loop that happens, over and over and over, million times a second in the body. So to start, the conversation, what to do with a baby stops to pee, let's first acknowledge that if the baby does have decreased urine output, there's a very high incidence of mortality. So this is a study that was performed, and they looked at three different approaches to urine output assessment. The top one is less than 1 ml per kilo per hour, which I think has classically been used for a long time. The second one, they used a slightly higher rate, 1.5 mils per kilo per hour, and then they used 2 per kilo per hour. And certainly the bigger you expand that, the higher the incidence rate. But you could see in this study that even 2 per kilo per hour in a baby really kind of increases the risk of death significantly. And so it's very important that we recognize it. There's a lot of controversy about, well, is it a signal of disease or is it a cause of disease? Whichever it is, I think it's really important to recognize that when you see it, at the minimum, it's a signal that something is going wrong, and it's really important that you recognize it and address it. Here's a study on premature neonates where they looked at urine output criteria that was similar to the ones I showed before. And in this situation, they found a 56% rate of oliguria, and again, with a very high mortality rate in those that had oliguria with an odds ratio of 12. Now, many times, and you mentioned the Awaken study, many times in epidemiology studies, we don't capture urine output. In the Awaken study, we had urine output for just the first week of life. This is a study in not in neonates, but in pediatric patients. And what I'm trying to highlight here is a couple things. So first, on the left side, you'll see that if you only use creatinine and you basically say it's too hard because it's hard to collect urine, or you ignore the urine output criteria, you're going to miss a lot of patients. There's many patients that have urine output AKI that don't have serum creatinine AKI. And on the right side, you could see the mortality rates based on different severities of acute kidney injury. And you can see that the highest one is on the right side, and it's the urine output criteria that really portends the worst outcome. And this would be a zero point 0.3 per kilo per hour. In the pediatric community, portended a mortality rate of about 33% if you developed less than 0.3 per kilo per hour. So oliguria is at the minimum a poor sign of organ perfusion, and that might be why it's so bad and why it portends poor outcomes. Um, this is a commentary that we wrote, really talking about how, whether urine output is the culprit of mortality or AKI is the culprit of mortality, or whether it's an innocent bystander and patients get sick and they happen to get oliguria on their pathway to death. Or perhaps oliguria is the canary in the coal mine. That analogy is that, when miners used to go down into the coal mines, they would bring a canary with them. And as long as the canary was whistling, they knew that they weren't at risk to develop poisoning. But when the canary started to have trouble singing, it was a sign that they need to grab their things and get out of the cave. And so, at the minimum, this is a sign of organ perfusion, and at the minimum, it should signal to you that there's something wrong with the patient and you need to start paying attention. And with the analogy of the coal miner, you better get your stuff and get out, or you better go fix what's happening in the underlying in the cave. And one of the main reasons that it does portend poor outcomes is because when you have the dysregulation of the fluid balance, you develop soggy organs. So fluid overload is a pathologic state where you have an excessive amount of fluid in your body. So similar to dehydration, dehydration is a state where you have a pathologic condition and your body is undergoing problems because you have too little fluid. Fluid overload is the opposite. It's the positive side of the fluid balance equation that is not really depicted by a specific number, but it's really depicted by organ sogginess, as I sometimes call it. And you can have dysfunction of the lungs, the heart, the gut, and you can have dysfunction of the kidney. When the kidney gets fluid overloaded, it becomes soggy and then can't function appropriately. And we all know that when patients get edematous in their lungs, they have interstitial edema, they have poor gas exchange, they require higher amounts of ventilator support, longer duration of ventilator support, and all that kind of leads to complications and problems. So, several years ago, through the Neonatal Kidney Collaborative, we performed a survey of neonatologists. We captured both advanced practice providers, nurse practitioners, as well as physicians, and we basically asked a bunch of questions about what their thought process was on fluid balance, et cetera, et cetera. And some of the things that we saw were really actually very striking to us. Uh, Well, so you can see here that according to the survey, the time when a nephrologist is consulted is a median of the survey was 25%. And the fluid balance number that that the group felt was the right time to begin renal replacement therapy was 50%. Um, David Selesky is going to dive into that next week to you guys and show you that in not only neonatal studies, but in pediatric and adult studies, this threshold where fluid overload is really causing harm, and where most um, experts now are thinking the right time to get involved with a nephrologist and to get on renal replacement therapy is really somewhere around 10%, 15%. And so if I'm a 70-kilo person, um, it's really when I gained 7 liters. According to this survey, you would people don't consider until I gain 35 kilos of fluid, 50% of my weight, before I start to consider renal replacement therapy. And that is very outside of how we're thinking about fluid overload in other populations. The other thing that we saw, and without diving into a lot of details, you can see here that there's a lot of heterogeneity of how people think about fluid balance. Some programs measure a daily weight. Some programs never measure weight on critically ill patients. Some follow strict I's and O's, and some don't. And when you look at how people approach the care of patients, some patients don't measure bladder pressure. Some programs don't measure. The vast majority of programs don't measure bladder pressures in neonatology, or measure uric acid, place of Foley, or give concentrated albumin for their patients who have fluid overload. Again, this shows that there's a lot of heterogeneity in how neonatologists are thinking about it. And I think there's an opportunity here to develop more evidence and to and develop better clinical guidelines to drive care, because at this point, everybody's doing all sorts of things. So when you have a patient who develops acute kidney injury and their kidney is not regulating the homeostasis, it becomes the job of us as physicians to kind of, but not only um, recognize the stimulus, the lower urine output, but also to impact care and to put the and to make the changes that are needed to continue and maintain that fluid balance. So how do we do that? So the first thing I think is really essential is that we really have to shift our mindset to fluids. Fluids are not just something that we give routinely that causes no harm. Fluid is a drug. In order to prescribe fluids, the physician has to order it, the pharmacist has to send it. Um, the nurse has to get it from some cabinet somewhere. and has to hang it, just like medicines are. And just like medicines, fluids can be underdosed and overdosed. And so I think it's really essential, especially when patients become critically ill with sepsis or when they're undergoing surgery or when they're having other types of issues that lead them to have risk for fluid overload, to really make fluid balance a part of your daily conversation, a part of your vital signs, and a part of your patient report. So we do this in our hospital, and we don't only use it as a number. We don't only say the patient had 200 mils in and 50 mils out. We try to calculate this fluid balance percentage, and we talk about it in context of the clinical effects. So if I tell you that the patient was 5% fluid balance positive yesterday, and today they're 10% fluid balance positive, and in that time, their oxygenation they needed to keep them oxygenated went from 40% to 70%. It tells you a lot of what's happening. So we try to pair the fluid balance with the clinical effects that it could be happening. Again, it's important not only to look at your daily I's and O's, but really to trend this cumulative fluid balance over time. The fluid balance definition that we use in neonates is primarily through weights. So we take the current weight, subtract the baseline weight, and then we divide it by the anchor weight. Um, it's that anchor weight can be challenging in neonates because we know that when they're getting good nutrition, they're growing by about 100 or 200 grams per week, depending on the situation. So it is an evolving baseline weight, but nevertheless, looking and finding that baseline weight is really important. So the way that I tend to do it is I look back to when the baby was not critically ill, and I use the most recent weight before the weight started to change drastically. Or, if a patient went to surgery, for example, or the patient got septic, I would use the weight the baby had prior to developing that condition. Excuse me. It's also very important to consider that there's different phases of critical illness, and during different phases of a critical illness, we have to consider the fluids that we're delivering based on the goals that we're trying to achieve. So, um, we recently we recently summarized what we've learned about fluid balance in neonates in this study that we called neonatal fluid overload: ignorance is no longer bliss. This was a collaborative approach between our neonatology team and our nephrology team, where we really reviewed the literature, provided concepts about why fluid overload is not always the same, and why the approach to fluid overload in a cardiac patient is different than the approach in a septic patient. And we put together some strategies to improve outcomes with an easy to remember mnemonic, can you pee lots? And I'm going to dive into that in a little bit. So this this paper really allowed us to develop for the first time a systematic approach. And, and part of the concept is that if someone is not making urine, it's not uncommon for us historically to try to do something on rounds. And then, maybe in the evening you do something else. And then maybe the following day you change that. This bundle is really thought of as let's do everything right up front and not have to just compartmentalize things to one thing at a time. Let's put together a whole list of things so that we can systematically think about what are the things that are important for us to remember from the onset and on daily assessment of the patient when they're developing excessive fluid balance. So I'm going to walk through those. So I think the first piece, and I think this is the part that may be the most critical, is really spending time thinking about what's the underlying. Why is my baby telling me that why is the baby dropping their urine output? This is concepts that we learned, back in medical school, but it's really important to kind of take a step back and really make assessments and look into your history and your laboratory analysis to think about what is it that's happening. Is it a pre-renal process where pre-renal meaning that there's low renal perfusion to the kidney? Is it intrarenal process where you are having, damaged cellular or structural damage to the kidney? Or is it a post-renal obstruction problem where you're not able to get fluid out? So in that construct, what happens if I was to be in the desert, in Australia, in the middle of the desert, and I had no access to water? Well, I think we would all recognize that if my kidneys are functional, okay, the first thing they would do is they would hold on to as much sodium and as much water as possible. The last thing you want to do if if you don't have access to water in the hot sun is to make a lot of urine. And so from a homeostatic perspective, if the kidney senses low renal perfusion, it's going to stop making urine. It's going to drop urine output. It's going to then determine what to do next. And so, if the kidney does its job correctly, um, you are going to increase your creatinine. You are going to increase your BUN. Your BUN creatinine ratio will be high. At this point, there's no tubular damage. Okay. And that's exactly what the kidney should be doing. So it's important to recognize it because if you think about it, people call that potentially acute renal failure or acute kidney injury. And I do apologize for all the nomenclature, but this situation is really acute renal success. The kidney is doing exactly what it's supposed to be doing to keep me alive if I'm in the desert without any water. Okay. So now let's think about it from this perspective. So let's say you see a patient who's having a lot of diarrhea, or let's say that you're not giving fluids, and the patient develops the situation of dehydration. So what happens if you as a provider recognizes that and you give fluids back to the patient? Well, the patient's going to improve, right? The patient's urine output's going to improve. The patient's GFR is going to get better. The patient's going to feel clinically better. But let's say that you saw a low urine output in this patient because they had low renal perfusion, and maybe they had low renal perfusion for other reasons, and you said, well, let's give a diuretic. So what happens in that scenario? Well, your kidney is actually going to respond to the diuretics because the tubular function is intact. If you have good perfusion to the kidney, the tubular function is intact. The diuretic essentially poisons the loop of Henle so that the loop of Henle can't hold on to sodium and water. And so you would see if you did this to me and I'm in a dehydrated state or I'm in a cardiac failure state, okay, I'm going to make more urine. And sometimes what I think happens is that we applaud ourselves for doing that, for giving diuretics and making more urine output in the face of low urine output. But we can all recognize that if you do that, what's going to happen to the dehydrated patients? They're going to get more dehydrated. And then after, if you do that over and over, you're going to end up with a very, very dehydrated patient who's very oliguric, who's then requiring a lot of diuretics to maintain their little urine output. And eventually your BUN is going to be 200 and your creatinine is going to be, it's going to be 4. So what happens if you do nothing to this patient? What happens if you just let things happen? Well, over time, what will happen is the BUN creatinine will go up, and eventually, what you'll see the patient do is they'll end up developing tubular injury because now they're not perfusing their organ because of the lack of low perfusion. So, another prerenal state that we could talk about is heart failure, and we could think about the same thing, right? It's the same physiology. The kidney's sensing the same physiology. So, what happens when the kidney senses low perfusion? They do the same thing. It holds on to fluid, it drops the GFR, increases the BU creatinine ratio, but there's still no tubular damage, right? So at this point, we have several choices. Okay, there's different types of cardiorenal syndrome. I'm speaking of the classic one where your heart's not pumping enough blood to reach the kidneys. So what happens in a situation if you give fluids? Well, you're going to end up with worse heart failure, right? And perhaps over time, the heart's going to get even worse because of diastolic dysfunction and excessive fluid into the heart. What happens if you give this patient a diuretic? Well, that's a good thing. That's what we normally do. Your fluid balance is going to get better, but you're not addressing the underlying cause. And so, just like the dehydrated patient in the desert, over time, more and more diuretics are going to need to be given to maintain the fluid, the urine output that you need to keep balance. What happens if you just sit and watch? Well, nothing's going to get better. It'll eventually get worse. What this patient really needs is to improve the cardiac function. If you improve the patient's cardiac function, you reverse the underlying issue that's occurring. Well, let's talk about a different situation. What happens if you have damage to the tubules? If you get a high dose of gentamicin, um, and you can have tubular dysfunction for many reasons that are not related to an acute process, but prematurity really kind of is a tubular dysfunction process where the baby's not able to hold on to salt and water appropriately. Patients with dysplastic kidneys can do the same thing. And if you have ischemic injury from perinatal asphyxia or shock, then yes, you have tubular damage, and you can have low renal perfusion in addition to the tubular dysfunction. But this becomes a more difficult situation to kind of address because even if you were to give diuretics, they may not work. In fact, most patients with tubular injury from nephrotoxic medications are actually going to not stop making urine because their tubular function is already is damaged. So they're going to be losing salt and water in the context. If you get to the point where tubular injury is leading to oliguria, you've had very severe tubular damage, and you're going to need to be praying and hoping that things are going to get better. It's not going to help it by improving cardiac function, and it's not going to help it from the perspective of diuretics. So it's a different approach and a different mentality as you as a physician when you have tubular injury versus and how to maintain homeostasis in that patient versus if you have a pre-renal state. What about sepsis? We used to think that sepsis associated acute kidney injury was all about ischemia and all about low renal perfusion. And that's the case in many situations. But just like you can have warm sepsis or cold sepsis, where, warm sepsis, you have bounding pulses and you have an increase in cardiac output, you can have increased perfusion to the kidney, okay? Increase overall perfusion, but you have a problem in the microcirculation in the kidney where the blood flow is not getting to the right places. In this and in this situation, really what we have to do, whether it's tubular function, is we have to maintain the fluid balance as best we can, recognizing that until the sepsis gets better, that the kidneys are not going to be functional. And sometimes we just hang out and do the pee-pee dance and hope that things get better in this septic patient. But there really is not much to do besides the standard approach to maintaining good organ perfusion and waiting it out until the baby gets better. And I mentioned that, there's different phases of fluid management, and the construct here is one that's been really kind of brought to light over the last 4 or 5 years as it relates to fluid balance and the phases and the goals of therapy in patients with sepsis. Mm. So this is a concept called the Rose diagram, rescue, optimization, stabilization, and now people are using the word de-escalation. But the idea being is that over here on this axis is fluid balance, and over here is time. When a patient comes in and becomes septic, they need a higher fluid balance to get them out of the shock state. And we all know, give 10 per kilo, 20 per kilo, increases fluid balance is the right thing to do. In this situation, a positive fluid balance is desired and needed. But as you kind of move forward into the optimization phase, your goal changes. So once the patient is more stabilized, meaning that they're not requiring higher doses of pressors, they're not requiring, boluses to maintain their organ perfusion, it's time to shift into a different mindset to keep the patient's fluid balance flat. And then ultimately, once the patient continues to improve, the patient will be able to de-resuscitate themselves, de-escalate that fluid balance and get back to neutral. And so where I think we as providers sometimes make mistakes is certainly if we're not given enough fluid in that early phase, I think that's a mistake. Certainly you can get too aggressive and give too much fluid. But I think this is the place where we really need to shift our mindset because at this stage, I think is where we make the most mistakes. And that once things are stabilized, we really need to shift our mindset and really work hard to look at and try to optimize and shift into this optimization phase and not allow the patient to continue to gain fluid while in that part of the thing. Now, sometimes if you have severe acute kidney injury and the kidneys aren't making urine, you may have a problem in that you will not be able to de-escalate the patient, and so failing to help the patient de-escalate is a problem. Um, it's specifically challenging in neonates because renal replacement therapy is hard, but we and others are really advocating to really if the patient is not de-escalating on their own, this is the time to begin the renal replacement therapy to prevent further fluid accumulation from happening, as Kara spoke to you last time. I think another mistake is to not provide nutrition to a child just so that they don't become more and more fluid overloaded. Kara spoke, I'm sure, about one of the indications for starting renal replacement therapy is the inability to provide nutrition without fluid accumulation is a reason to start renal replacement therapy. So don't start people just so that they don't become fluid overloaded. And then certainly if you love big swollen babies and you idolize the Michelin Man, that's certainly also a mistake. So I'm going to shift to the next one in our Canyu-Pilots mnemonic, which is albumin. So albumin is often used in critical care medicine. There's a lot of controversy. There's not a lot of data in neonatology on its use using concentrated albumin. And there's not a lot of data looking at it in the context of a hypotensive patient who has a low serum concentration of albumin. So there's no large studies that have evaluated it. And so after a lot of discussion between our team, we decided to put together a practice where we monitor albumin and we target somewhere in the order of at least 2 milligrams this should be grams per deciliter, and we give concentrated albumin about 1 gram to 2 grams per kilo over 4 hours, followed by a dose of diuretics. Um, and certainly there's controversy in what we used is we wrote that you should really consider a higher threshold for giving it in the severe LGANs, especially in the first few weeks postnatal. N stands for nephrotoxic medications. So be a ninja. Ninja is a quality improvement project that we use in our hospital to really mitigate the ill effects of nephrotoxic medications. So if you have a patient who's oliguric, who has acute kidney injury, really try to avoid pouring fuel into the fire. And if you need to give nephrotoxic medications, then you can, but use them for the shortest duration that you can't possibly, and try not to stack 1, 2, 3, 4, 5 nephrotoxic medications on another. U stands for uric acid. There's data and a lot of physiological reasons why uric acid can propagate acute kidney injury and propagate oliguria into a positive feedback cycle where as you accumulate uric acid, it crystallizes and blocks the collecting tubules, which then increases your creatinine and drops your GFR, which then decreases your uric acid excretion, and this positive cycle can make everything worse. There have been studies. This is some studies in neonates back from 2010, not randomized clinical trials, but observational studies that have shown that in patients who have very high uric acid levels, one small dose of rasburicase will really get that uric acid down to into the very very low ranges, and cause improvements in urine output and creatinine. So this is a study, and basically in this small cohort, there was a significant drop in the uric acid, and you could see that there was a quick response with a drop in creatinine, increase in urine output, and steady improvements without the need for dialysis, without rebounding of the uric acid, and no treatment-related side effects. The other U is ultrafiltration, and you've heard about this from Kara. If you cannot maintain fluid balance, or if you want to prevent excessive fluid balance, then technologies like you see here, whether it's peritoneal dialysis or continuous renal replacement therapies, are options to help the baby maintain that fluid balance. And on the right side here, you can see that these three are very small filters and very small machines that we have adapted and other people have developed to specifically to take care of small children. Now, this is possibly the most important part of cannupilates. So, who knows this pearl? Um, what blood pressure target should we use for neonates? Anybody? How do you guys pick what blood pressure to use in a baby who is oliguric? Well, um, a lot of places, and I don't know what it's like in Australia, but there's this idea that you should use the corrected gestational age or the post-menstrual age. So if you're a 39-week baby who's 1 week old, then a MAP of 40 should be sufficient. Well, let's talk about that for a minute. So where'd that number come from? Well, you can see here, these are some graphs of normal blood pressures over the first couple of weeks of life for different gestational ages. And what you can see is that these thresholds that they're using are actually the fifth percentile. So the fifth percentile is the corrected gestational age. And that may work fine, but if you have a patient who is not making urine, then let's target higher blood pressures. And so here you can see, for a 39-week baby, that the mean arterial pressure of 40 is the fifth percentile. What we did in our bundle is we said, well, why don't we try to increase that? Why don't we systematically go up? And so what we'll do is we'll target the 25th percentile, and then if that doesn't work, we'll target the higher ones. But really, the goal shouldn't be a number. It should be, end organ perfusion, and end organ perfusion as measured by urine output. And so sometimes um, the other really important thing to remember, and why I think just picking a number isn't sufficient, is because the renal perfusion pressure, okay, which is really what we're targeting here in a patient who you're needing to make increased urine output, especially if you see that rise in BU and creatinine and the oliguria like you would see in a septic patient or heart failure patient. But this pre-renal azotemia, okay, is telling you that you don't have adequate renal perfusion pressure. So renal perfusion pressure is equal to the mean arterial pressure minus the CVP, and it's actually also minus the intra-abdominal pressure. So if you have babies who have tight bellies, or babies who have a lot of backup of venous pressure, you need higher MAPs to perfuse their kidney. So it's hard to measure CVPs. It's hard to measure intra-abdominal pressures. We certainly can to understand this better and to target a different number. But really, kind of our approach is to titrate upwards to the 90th percentile steadily and find that mean arterial pressure that the baby needs to make good urine. And so we'll, steadily increase to 25th percentile, 50th percentile, 75th percentile. We try not to go above the 90th percentile. And what you sometimes will see is if you look carefully into the medical record, you'll find that, when I hit the mean arterial pressure of 55 was really when you started to see that change in urine output. And so then we'll use that to guide us over the coming days until the patient's fluid balance comes back to normal and the patient can maintain its own renal perfusion pressure. Now, everybody asked me at this point, well, which pressor? Um, I'm not an expert in pressors. I'm going to let you choose whichever one you want. I'm a believer that it's more important to have the right amount of pressure than to pick the right one. And I'll let you, as neonatologists, get into that argument. So the next letter in Canyu-Pilots is Lasix stress test. So it's really known as a furosemide stress test, but the mnemonic of Canyu-P-FOTS was not really as catchy. So we went with Canyu-Pilots. And what this what this idea is that if you give it, and we all do this all the time, if you give a big dose of diuretics, okay, you're going to know a lot about the kidney based on whether it makes an increase in urine output or not. Okay. But the idea here is don't wait until this afternoon or tomorrow to look at that. The idea is give a big dose of Lasix and look at what's going on in the next 2 hours. And that's going to tell you a lot about what's happening in the kidney and it'll drive your next move. So the idea is you give one big dose of diuretic. You could pick Bumex if you want, or we usually use Lasix. 1 to 1.5 grams per kilo is plenty. If your patient is not making, over 1.5, 2 mils per kilo per hour, then there's something wrong with the system. Okay. Either you're not perfusing the kidney, or you have tubular damage already, or you have a urine obstruction. There's something wrong with the system if you don't make urine. On the flip side, if you do make urine, that means the system's intact. And what it's probably telling you is that the kidney really needs more perfusion. And so here's kind of this idea of fluid responsiveness. On the left side is kind of the adult. On the right side is the for children. If you're fluid responsive, if you're furosemide stress test responsive versus not responsive, it tells you what's happening to the kidney, and it really should drive your next move. Again, if you have a response to diuretics, okay, if you give Lasix and you have a good urine output, you probably need more renal perfusion because the system's intact. You don't have damaged tubules. So the other part about this is really thinking about, what Einstein said, that insanity is doing the same thing over and over and expecting different results. If you if you give diuretics and it works, you learn a lot. If you gave it and it doesn't work, you really need to, think about what's next. And the answer is not give another round of diuretics. It's not finding a different combination or dose of diuretics. So resist the temptation to redo the test with a better diuretic. And we've all seen this in clinical practice, right? You see a patient who's a little bit fluid overloaded and you give a diuretic and maybe it doesn't work so well. And so the patient becomes more edematous. And so you come the next day and you say, well, let's go to Q6. And then the next day, the resident says, well, I heard that a drip is better. So let's try a drip. And then the next day, someone pulls out an article about Bumex. And then they says, well, maybe a Bumex drip is better. And then the next day, the nephrologist comes and adds, metolazone or hydrochlorothiazide. And as you do that, your patient becomes more and more fluid balance positive. So resist the temptation to keep doing it over and over with failed tests. When you find a patient who's not diuretic responsive, it's really time to think about other methods to improve their fluid balance. Stands for output. Assure that there's adequate output. If you have obstruction, go relieve that obstruction. That one's the easiest, I think, for us to think about. But you have to remember it or you're going to get yourself in trouble. And again, I remind you that we should measure it just like every other ICU patient in the world has good urine output measurement. We should be measuring it in neonates and tracking that output. The last couple is this is a total fluid intake. Um, Remember that your total fluid intake is not the same as your total caloric intake. So we have to decrease fluids in these patients. That doesn't necessarily mean you have to decrease calories. It just means don't give dilute calories. Concentrate your feeds, concentrate your fluids as much as you possibly can. And remember that malnutrition is bad for growing babies. And the question becomes in an oliguric patient, how long is it okay to withhold nutrition to prevent fluid balance? And as I mentioned, not being able to get nutrition is an indication to start renal replacement therapy. We had steroids because that's what our neonatologist really wanted. And they believed that, if you have a hypotensive patient who's not peeing, and if you query folks, around half of the nephrologists that I've spoken with start with steroids for hypotensive patients. Others use it as second line therapy for hypotension. So something else to think about in a patient who you're having trouble with urine output. And so putting this all together, you can kind of start to get a sense to how I think about a consult or how I approach a patient who's oliguric in a systematic way. And the question that comes up now is, well, does this work? Well, we did a study using this Candy-Pilots bundle. It was a quality improvement project where the concept being that if we can identify patients who are high risk to develop fluid overload and address the fluid balance from the very beginning, and use the Candy-Pilots bundle to help the management of fluids early in the course of critical illness, well, maybe that will improve their clinical outcomes. And so I'm going to show you data that we collected before we did the intervention being really just education and systematic approach. There's a training period for about a month, and then you'll see the post-intervention data. So our cohort was children who were admitted to level 4 nursery. A lot of them were surgical medical patients. This is not your typical, uh, premature baby land. This is more of the kind of surgical medical complex patients. Um, and we identified patients on a daily basis, and to enter the bundle, they had to meet one of the following criteria: sepsis requiring antibiotics for more than 3 days, new onset hypotension, major surgeries, neck, SIP, severe AKI, or clinical edema, or a greater than 10% fluid balance positive. Um, Here's some details on the bundle. The moral of the story is that we assessed and we did the bundle on a daily basis until the patient was no longer met the criteria to continue the bundle. And so the patient can come out of the bundle when they did not have AKI. Their weight was close to back to their baseline, and they were on less than 2 pressors. And here's what we found. So you can see here, there's the intervention date month in the middle where we did the education, and you can see this is the percent of ventilator-free days across our NICU, and you can see a significant increase in the number of ventilator-free days that happen around the second or third month after the intervention. Um, and you can see that this was sustained for approximately 6 months. So not only did we see an improvement in ventilator-free days, we saw an improvement in oxygen-free days, decreased length of stay. We did not see any major demographic differences in the pre and post era, and we did not identify safety issues. Certainly, this is early data. This is a signal that this bundle is effective, but certainly there's some alternative potential reasons why we saw this effect, and so we need to have more data to show to be able to confirm our findings from this small single center study. So, in conclusion, when urine output drops, first understand why and then make the right decisions. Maximal medical management is more than just trying different diuretics. CanUP lots is a mnemonic that may help you deliver care, and more studies are needed to understand what interventions, what thresholds, and how to implement tools to assist providers in managing these patients. So thank you guys. I'll stop there and welcome you to our next course if you wanted to. And there's the fifth International Symposium on AKI. I apologize you if you didn't. This was the middle one is neonatal kidney collaborative meeting that we had when back in April. So ignore the middle one. But you're definitely invited to the fifth International AKI Conference in Cincinnati and to our next courses where we talk a lot about the medical management, but also the renal replacement management of babies. So I will stop there and I'm happy to take any questions.
Thank you, David. Thanks so much. That was a great overview with fantastic sort of images and taking us to the story of oliguria, the definitions, the problem and the consensus of what is fluid balance, that fluid is a drug, I think is a really important message. And then you took us to the physiology of not only renal failure, but a different, I call them phenotypes, whether it's glomerular or tubular or even non-renal, which can all create sort of this fluid overload. And then that can you pee lots, that is just fantastic way of thinking about it and managing your patient on a day-to-day basis. What is going on? What can we do? There is some questions in the chat box. Let's start with Fazul has a question about perfusion and how can we measure perfusion, particularly to the kidney. Is there a role for NIRS?
Yeah, it's a great question. A lot of people, the answer is it makes sense if you're not oxygenating and you're looking at oxygenation tensions that it should be able to help you understand what's going on. Certainly, if you find a patient that has very low NIRS, I think it's a signal to increase perfusion. Um, I think that there hasn't been, a tremendous study that has shown us how to use it. And so I think that it's a tool that is waiting for the right study to prove that it's helpful. But we use it in critical ill patients as a marker of perfusion, organ perfusion. Yeah.
Yeah, no, I can imagine because the kidney is very pressure dependent, and I think it would be quick to pick up. In prems, it's not very common yet, but I can imagine in your patient population it is. The next question is sort of related for Fazul. It goes in a lot of detail, but I guess the essence here is, you mentioned on your patient population and not the neonatal sort of fields, but what about those little 700-gram babies? How should they be treated different, and particularly with the CanUP lots?
Yeah, it's a great question. I think that the physiology is the same, whether you're an adult or whether you're a prim, from the perspective of, if you have low perfusion, you got to fix that. If you have a blockage, you got to fix that. If you are gaining too much fluid, it doesn't make sense to give dilute fluid in a patient who's already fluid overloaded. Um, Certainly there's not a ton of data on uric acid in that population, but I've seen it used and I've seen it work where, a patient that small has a very high uric acid level and, and we're nervous about it and we debate about it and we look at the kid and say, well, do we want to dialyze this baby or do we want to try to fix the uric acid and hope that that's helpful? And we've seen success a couple times doing that. So I think it's worth trying, recognizing that there's, not big randomized clinical trials on it, but it's a relatively safe drug. Um, One caveat to that is if you have a patient with G6PD, you shouldn't be using rasburicase. And so we actually screen for G6PD before we give it. Um, so um, so yes, I think that the CanUP lots that we developed for neonates isn't perfect. It needs to be fine-tuned, but it's the same thing that I would use, if my grandmother was in the ICU. It's how I would think about it. Yeah. But it
Um,
was
uh,
developed for babies. Yeah.
yeah, a relatively simple question. So, oliguria, the definitions and the different studies from your group and other groups have tested against mortality, but they were all after the first 24 hours of life. Is the definition of oliguria different in the first 24 hours of life versus later, or should
Yeah,
it be?
I think it should. I think we all recognize that even, term babies who are doing well, who had normal APGARs, who are breastfeeding, sometimes takes a half a day or a day to have their first void. So I don't think that I've never seen data that looks at urine output thresholds in the first day of life as predictive of anything. Um, so I think it's a good question and probably deserves some thought. Certainly after day 2 and 3, it's important. But also remember that that a low urine output is important for two reasons. One is a signal potentially that there's something wrong. Um, and one one thing to remember is that nephrologists don't think about mils per kilo per hour, believe it or not. We're much more worried about that fluid balance, the daily fluid balance. And so if you go and go with your friends and have a bunch of beer and you have 6 liters of beer and you're peeing 2 liters, then you got oliguria because you're going to have an inappropriate fluid balance. And so it's really about matching that intake with the output, and assuring that there's balance. So clinically, to me, it's much more important to look at your daily fluid balance and your cumulative fluid balance than an absolute number of oliguria. In epidemiology studies, people have to pick a number, and certainly I made an argument that even though clinically we all say 1 per kilo per hour, others have said that that's maybe a little bit too low in neonates. But again, if you're not giving a lot of fluid and the baby has low urine output, well, that's normal. If you're giving a lot of fluid and the baby's making 3 per kilo per hour, then that could be an abnormal signal that the kidney's not really properly doing its job.
Think that makes a lot of sense. You already mentioned in one of the scenarios of what not to do, but the difference between bolus versus infusion of furosemide. Hmm. It's a question which comes up quite regularly in clinical practice.
Yeah, I think that it was certainly initially used as a bolus. Lasix was used as bolus, and I think more recently we've developed as a drip. Um, I think that if you're using diuretics for more than a day or two, you know, you're whether you do as a bolus or diuretic, you're just trying to find that. Again, I go back to your goal is not to make a certain amount of urine. Your goal is to make urine that matches your fluid balance goals. And so if you have a patient who's, let's say, had AKI and they're very fluid overloaded and they're opening up, and you want to use diuretics to get them off a ventilator, and you target 200 mils a day as your net negative fluid balance, and you're not reaching that with Q4 or a Q8 hour Lasix, then go up to Q6 or try a diuretic or increase the diuretic. Um, so I put less weight on which diuretic to use and the dose and the mode, and more on thinking about what your goals are and trying to maintain those goals, and then being a smart physician and making adjustments. But again, I think people get sometimes stuck in, they're using diuretics every day and they're using more and more, and they fail to go back and say, well, why is the patient not making urine in the first place? And let's fix that.
That's sort of related with the last question. I think it's time for our last question, which the furosemide stimulation test. is sometimes with a fluid bolus or without a fluid bolus. But I think you already sort of said it's more important that there is a fluid balance, not a bolus. Would you use the fluid bolus with and the frusemide challenge test?
Yeah, I think certainly the initial studies in adults, they wanted to make sure that you're not giving diuretics to test the system in dehydrated patients. Um, so if you think someone has a low intravascular volume and you want to assess whether the kidney's intact, then definitely give a bolus of fluid beforehand, so you're not making the patient dry and making their clinical situation worse. If you have a patient who's got very big intravascular volume, um, you don't need the bolus to do that test, if that makes sense.
It is 2 past 2. Thank you so much, David, for staying up late and giving us this fantastic presentation about these patients. We're going to continue on next week. Hope you can all attend again next week. We have the recording. We'll send you the email with the recording, David. But thank you so much.
My pleasure. Reach out to me or any of us if you need help, and we would love for continued participation, with this work and through the Neonatal Kidney Collaborative. Lots of resources, a great bunch of people. Let us know if there's anything we could do for you guys.
Oh, absolutely. We are, I think we are in we call the kinderschoenen, like the baby shoes of developing renal oriented approaches in the NICUs. So we certainly in Anchor will lead some of that, hopefully in Australia. So we will definitely reach out and take you on your generous offers.
Great. Well, you're in good hands.
All right. Thank you very much. And thank you all for attending.
Take care, everyone.